Welcome, everybody. We are glad we are back to you again, Latin America and Africa, in a new format, challenging cases that we hope will be beneficial to everyone. It was a great pleasure to work with our Latin American colleagues to create this educational event, blessed and supported by so many societies in both continents. This time, we are lucky we have translation to 3 languages, English, Spanish, and French. Please select the language of your choice. This event could not have been possible without the deep cooperation of Professor Oscar Bottini of Argentina and Professor Lorena Grillo of Costa Rica. Professor Sergio Genesini of Ferrara University was always supportive in every possible way. And finally, Dr. Wasila Taha, the energetic secretary of our association, Egypt and Africa Vein and Lymph Association, is really the backbone of every successful event. We are honored to have distinguished speakers who will share their valuable experiences and world-class experts to stimulate the discussion, moderated by our distinguished colleagues. We have a new section in this webinar, Unmet Needs, which will be covered by 2 eminent experts. Nothing could happen really without the unconditional support of our main sponsors, Servier, and our co-sponsors, ProMed and Canon. And now I'd like to leave the word to Dr. Wasila to introduce our guest of honor. Dr. Wasila, please.
Yes, Dr. Rashad. Thank you for the nice introduction, Dr. Rashad, and I would like to welcome everybody on board to our night today, Saturday Night Vein Talks, in the second scenario with the LAT-AF 2.1, bridging both continents, Latin America with Africa. And representing our continent, Africa, we cannot go higher than Her Excellency Ambassador Mona Omar. We called her Mama Africa, and this is very obviously for her great achievements and endeavors. And now we have a recorded video from Her Excellency. Dr. Rashad, please, the video of Her Excellency.
The capacity to fly in Africa? How can we change the image of our dear continent so as to make it rise and take its well-deserved position among the most developed continents? Do you know how? Throughout the years I have spent in the African continent as ambassador and as Deputy Minister of Foreign Affairs of Egypt, I became very much convinced that only through sciences and technology, through the development of our infrastructures, that we will be able to achieve our aim. Healthcare, education have to be targeted by each one of us. And in this difficult time of COVID-19 spread, participation in training and learning webinars is very, very important. Venous and lymphatic diseases are very much needed fields of medical services and education in Africa. Our African continent is largely deprived of advanced education in this field. Through this webinar, I hope we can reach out to all our African medical specialized institutions for a knowledge transfer and experience exchange, so we can bridge the existing gap in this vital field. Dear all, I'm sure that together, armed with knowledge, sciences, and education, we will wake up the giant. We will rise and change the image of our dear continent. Thank you so much.
Thank you. Please, Dr. Wasila, could you introduce the next case?
Yes, and as Her Excellency said, we wish very much to wake up our sleeping giant, our continent, Africa. And now, with huge honor, I would like to introduce the godfather, actually, of all these streamlined initiative and educational activities, Dr. Rashad Bishara. He doesn't need any introduction. In fact, he is the president of our association, IVLA. And he is the leading figure for the field of the venous and lymphatics in the Egypt and the whole region. And for a personal level, he is a long life associate and long life person. Dr. Rashad Bishara, the podium is yours now to introduce and to present your challenging case.
Thank you, Dr. Wasila. It's my pleasure to share with you this interesting case. It's about extensive acute iliofemoral DVT on top of chronic post-thrombotic occlusion. I would like to present this on my behalf, on behalf of my colleague, Dr. Wasila Taha. It's about a 34 years old male patient who's a professional photographer who presented with 24 hours history of sudden severe leg swelling. He had a history of chronic leg swelling going on for many years. Actually, he could not complete a normal day activity, had to interrupt his day and sit down a little bit, elevate his leg. He had a history of DVT 12 years ago. He had no other comorbidities. And this diagram represents his duplex on presentation. He had an occluded deep venous system on the left side, extending from the popliteal vein up to the proximal common iliac vein. The femoropopliteal segment was distended, indicating a fresh thrombus, while the iliac segment was retracted, indicating a chronic thrombus. Dr. Wasila? Dr. Wasila?
Yes, now we have a question for the audience actually. How we would treat this patient? We have a poll for this question, and please select just one answer between 1, 2, 3. 1 is anticoagulation, 2 catheter-directed thrombolysis, 3 mechanical thrombolysis. And we get the results instantly now.
Please select 1 or 2 or 3.
Yes.
We'll wait 5 seconds and show the results. Khaled, could you please show the results?
It's 45% for the catheter-directed thrombolysis. It got the highest score.
But still 27% for anticoagulation and 27%, which is very important. We selected catheter-directed thrombolysis, and I would like to go through the procedure with you. This is the procedure. This is the initial image, which shows total occlusion of the femoropopliteal segment. And this is the wire and catheter passage. And it was actually quite fast, indicating this was a fresh thrombus, up to the groin. And once we reached the groin, there was a lot of resistance to the passage of the wire. And it was passed up to the external iliac vein with a lot of difficulty. And now trying to pass the wire up to the common iliac vein, it looped twice. Eventually, we could put the catheter to the common iliac vein, which shows post-thrombotic sequelae. And then we attempted to go with the wire through the stenotic common iliac vein into the inferior vena cava. And here we are, we reached the inferior vena cava. And then a thrombolytic catheter was placed, extending from the common iliac vein down to the popliteal vein. He received catheter-directed thrombolysis, and this is the result. Good flow, reasonable flow through the femoropopliteal segment up to the groin, but at the groin, complete discontinuation of contrast, and the iliac veins were occluded or appeared occluded and replaced by large collaterals. Now, Dr. Wasila, please.
Yes, Dr. Rashad, it's quite interesting, challenging case, in fact. And now facing a new challenge, how we would like to manage this part. And also we have a poll for this 1, 2, 3, 4. Number 1, continue catheter-directed thrombolysis. 2, discharge on anticoagulation. 3, recanalization with venoplasty. 4, recanalization and stenting. And while we are waiting for the results, meanwhile, we'd like to get opinion, just short comments from our distinguished panelists for this section, who will properly introduce, of course, later on. We'll start by Dr. Osman, please. If you have any comment, how would you manage at this level of this case, please? Dr. Osman Mahmoud. Unmute yourself, Dr. Osman. Okay, thank you, Dr. Osman. Dr. Marcelo Falas, please. Would you have any comment at this level? So we'll go for recanalization and standing too. Okay, Doctor. Okay, thank you. Dr. Swat, do you have any comment? How would you manage at this level?
Dear Wasila,
Hi.
hi everyone, and I just want to say that this is one of the most challenging or difficult to solve situations, because this is very there are lots of contradictory points in such cases, because yes, we know that this patient has lots of complaints and we have some fresh thrombus. Of course, to improve his or her symptoms, we have to do something, but we are still not 100% sure that this is a chronic one, acute on chronic thrombus. So making such type of therapies in the long term, we don't know how to they benefit. Of course, I know that we can thrombolize and stent these patients, but without having good clue, especially about the inflow, our such type of therapies would also play. Yes,
which
would
answer will go for recanalization stenting,
yeah.
or what will be your answer for this point?
Yeah, actually, at the beginning, I even may stay just only with anticoagulation, maybe to make a highlight the discussion.
All right.
And then maybe at the end we can go to another one.
Perfect. And we have also Professor Wittens raising his hand. Maybe we have to take the opinion of Cs before the results of the poll. Dr. Rashad, please. So Dr. Wittens, please.
Yeah, I just want to comment, because I'm fully aware what Dr. Dukanji is saying. In fact, we would never have started anything in this patient before we had an MRV, because the MRV would give us the impression what's old, what's new, what's in between, and we would have a strategy up front. And if we would have, as here is the common femoral vein is already damaged, so you need maybe an endophlebectomy, maybe you need to stent the rest of the, maybe it's also possible that it's still a lot of clot in the iliac tract, you don't know by phlebography. So you might have a very short stenosis or occlusion in the femoral vein, but you don't know what's up there. So I'm missing, let's say, diagnostic material in such a case with the previous DVT. I would not go as fast as this is presented to go in. I will do an MRV or a
for the work up for the case prior intervention. We would like to add the MRV. Thank you.
Then you make choice.
Now maybe we have the results. Khalid, we have the result for this segment, please. 65%, quite significant in vein recanalization and stenting. Okay.
Very good. So we decided to go for iliac vein recanalization and stenting, and I would like to share with you this intervention. This is the initial image, which shows that the iliac veins are occluded and replaced by collaterals, which means it's a chronic occlusion. We tried to find out the microchannel through which to pass the wire in the catheter. Actually, it was not so bad, not as bad as we thought, because it's 12 years old occlusion. It passed with relatively ease, and this is the proximal common iliac vein, which is severely stenotic. The wire has passed through to the inferior vena cava, but the 5 French diagnostic catheter could not go through, indicating indeed a very severe stenosis. And this is a low French, 4 French support catheter, which also could pass into the inferior vena cava only with great difficulty. Eventually, we could get there and took a venogram, and this is the vena cava, which is quite normal. And then we dilated the whole tract from the proximal common iliac vein down to the common femoral vein, at first using 3 millimeters balloon, and then 8 millimeters balloon, all the way down. And now we'll see the result of the venogram following balloon venoplasty. Of course, there is a channel, but of course it's inadequate. So we placed this stent. It's a dedicated venous nitinol venous stent, silver vena of Cook. And after placement of the stent, this was dilated using a large balloon. It was 60 millimeters balloon. And then another stent, a shorter stent, was placed to cover the common femoral vein. And this was also dilated with a 14 millimeters balloon. And now we'll see the end result of this procedure. This is the venogram showing reasonably good flow into the proximal femoral vein and common femoral vein, and a nice flow into the external iliac vein. And then we will go up, and this is the common iliac vein anteroposterior view, which is quite reasonable. This is the common iliac vein in an oblique view. And as you can see here, there is an indentation into the stent, which we decided to leave because we thought there was a good flow. This patient was discharged on low molecular weight heparin in therapeutic dose, and he came in 1 week later for duplex scan. And to our surprise, the duplex scan showed total occlusion of the stent, total occlusion of the common femoral vein, total occlusion of the femoral vein down to the popliteal vein. So we were back to square one. We decided to take him back to the cath lab and do lysis again and see what's wrong. So we did just this, and this is the initial image, which shows occlusion of the femoral popliteal segment up to the iliac vein. And we noticed this is the indentation that we noted the last time, and we decided to leave alone. This time we redilated the whole stent, especially this part, and this is the end result. Again, reasonable flow into the femoropopliteal segment, adequate flow into the common femoral vein, the external iliac vein, and the common iliac vein. Now the indentation has gone. It was adequately treated with the last balloon. This patient was discharged again on low molecular weight heparin. This time we added aspirin, and then he was converted to DOAC 1 month later, and was kept on DOAC for 6 months. We are now 5 months after the procedure, and he came in only very recently, last week, 5 months following the procedure, and the duplex scan showed completely patent deep venous system, and to our own surprise, his valves of the femoral segment and the popliteal segment were also patent. Post-intervention, this patient remains asymptomatic, and these are his words: "I never felt as good. Actually, now he plays sport and he lost weight, etc., etc. Big change in his quality of life." The lessons we learned: we didn't use IVUS in this case because it was not available. IVUS is important. It identifies the disease segment, optimizes stent position, checks the final result. Had we used IVUS in this patient, probably we would have corrected the stent indentation and avoided the rethrombosis. The second lesson for us is that intervention for symptomatic occlusion of the deep venous system can have a deep impact on the quality of life. Thank you very much for listening. Now, Dr. Watila, please introduce the discussants.
Yes, thank you, Dr. Rashad. Maybe a lot of take-home messages. Maybe as Professor Witten said, for the workup, we would add the MR venography. Now it's a true pleasure and delighted to introduce our compatriot. He is actually the treasurer of IVLA, our association, and also is the treasurer of the medical syndicate. So this guy has a lot of money under his hands. Dr. Osman Mahmoud, the floor is yours now. If you have any question to address to Dr. Bishara, please.
Thank you very much for your good questions. It's the hospital policy to check for COVID prior to admission. So he was actually checked for COVID, he was negative for this. And regarding IVUS, absolutely agree that IVUS is very helpful. Thank you.
We will go forward, Dr. Rashad.
Yes, please.
Now, truly honored to introduce a huge professional and a leading figure in Latin America, in Costa Rica. He is the Vice President of the Costa Rican Vascular Surgery Association, Dr. Marcial Falas. We are truly honored having you, Dr. Falas, and the floor is yours now, please. So you would like to address this question to whom? To Dr. Bishara or to Dr. Bishara? Did you get the question, Dr. Rashad? You get the question? You got the question? Okay, please, Dr.
Thank you very much. But the big challenge in this type of webinar is to keep on time. So we cannot have all the panelists answer your question. But the next discussant is Dr. Suat Dugansi, who is a real expert. So I'd like to pass on your questions to him. So Dr. Dugansi, would you like to answer Dr. Farah's question, please?
I wish to introduce Dr. Duganji, Dr. Rashad, please.
Yeah, please go ahead.
I can say he is a good friend of our societies and is very supportive doctor to our community here in Egypt and the whole region. Dr. Suat Dugansi doesn't need any introduction. He is the professor of venous surgery in Gülhan School of Medicine, Ankara, Turkey. Suat, we are really pleased and delighted having you among us today. And the microphone is yours now, Suat, please.
Thank you, dear Vasila, for the nice introduction and invitation. Yeah, actually, especially for the scientific background, we know that for the people with femoral popliteal lesions, it is not recommended to make such type of interventional therapies if the iliac veins are open. So even from the ATTRACT trial, we know that the femoral popliteal segment occlusion patients is not having any beneficial therapies from having such type of catheter-directed therapies. They should be on anticoagulation. But for the iliac part occlusion, especially even for the such type of acute on chronic deep vein thrombosis, as Dr. Wittens also mentioned, it is a very, let's say, contradictory conditions to make any therapy, because I think the most important thing when planning and deep venous stenting, we should be good information about the inflow, because although we are giving them good anticoagulation protocol after venous stenting, as long as you don't have any good inflow, your stents will be occluded after whatever you do. Therefore, I think if we have a good insight about our inflow, of course, we can make an extensive therapy like this, give the patient PTA and stenting, and put them on a high therapeutic level of anticoagulation. But this is a really good decision making, because in such conditions, especially in the acute situations, although we, let's say, make them catheter directed therapies or thrombolytic therapies, we should be 100% sure that we cleaned maybe all the thrombus inside the vein. Otherwise, putting such a stent, and we are also making them in a highly, let's say, hypercoagulable situation after making therapies. So we also maybe trigger the coagulation cascade by making such type of therapies. But if we have IVUS on the board and we saw that we cleared everything and we have a good inflow, and I think we should have, as Dr. Wittens explained, MRV in advance before doing anything. And after the therapy we gave the patient, we should check it with IVUS. And if we have good inflow and we are sure for it, we can go for the therapy. But if not, this is challenging, because if we have a stent occlusion afterwards, I think we are making worse the situation for the patient, and we are maybe causing them to lose their another therapy. That is what I can explain.
That's perfect.
Thank you for
very good, and very good points to arise, Dr. Doganji. Thank you so much. And now coming the segment for the Q&A box of our audience, and we have so many, about 5 or 6 maybe questions. And the moderator for this section will be Professor Lorena Grillo. She doesn't need any introduction. Actually, she is one of the pillars of such educational activities. Lorena, she is the president of the Phlebology, and the podium is yours now to select the most liked question. Lorena, it's yours now.
I didn't quite.
I didn't actually quite get stent sizing. Yeah, stent sizing, we use large dedicated venous stents, like diameter 40 millimeters, 60 millimeters. We can have an idea about the native diameter of the vein by measuring the contralateral side using IVUS or using vascular ultrasound or using CTV. But usually we use 14 to 60 millimeters diameter. We use a long stent. We try to cover as much as possible of the disease segment with one stent. But in many cases, we need to use more than one stent to cover the whole disease segment. Now, regarding anticoagulation, there are no clear guidelines regarding this. Actually, I enjoyed listening to a very nice presentation from Dr. Doganji yesterday regarding post-stenting anticoagulation. What we do is to put the patient on enoxaparin for something like 4 weeks, and then to convert the patient on oral anticoagulation for at least 6 months. Oral anticoagulation, at present, we use the newer ones. Thank you. It's certainly an option in the classification of C. Wittens and Human-Gelai, and we are lucky to have Professor Wittens with us today. The classification, the class 5 where they don't have any patent, any patent inflow. They have occluded common femoral vein. Those patients you cannot do without endophlebectomy. For class 4, we actually prefer to do it all endovascular and to have the stent go all the way down to the inflow, that is the profunda femoris vein, plus or minus the great saphenous vein. In rare cases, we resort to endophlebectomy. Endophlebectomy is an operation that takes a very long time and is associated with a significant number of complications.
Yes,
thank you. So
we'll
Christina would
continue.
like to present.
There are some participants, they put their questions on the chat box. Please go to the Q&A box, please, to put your questions, not on the chat. And now we continue. We have a new segment in our platform. It's the unmet needs. And this time we have on board Sergio Gianissini. And I don't know how to introduce Sergio Gianissini. I think the phrase, the person who doesn't need any introduction, it fits very well with Sergio. Of course, all of us know very well Professor Gianissini, the president of the WIN Foundation and professor at Ferrara University in Italy. He is conducting so many educational activities online, and they were really very successful ones, and we did contribute together so many initiatives. Professor Gianissini, we are truly honored having you with us for this section of the unmet needs, and with the previous conversations, there is a lot to say for the unmet needs. Sergio, the floor is yours now.
Thank you so much, Wasila. Thank you so much to all the ones who have been involved in these educational activities, and congratulations for this upgrade of LAT-AF, adding indeed also the unmet needs, but also the involvement of rotating continents. I've been asked by Professor Bishara to touch the topic of what I felt we could consider unmet needs following his case, of course, apart on the very interesting topics that have been already raised. So while I was listening to his talk, I focused on some sentences he used. Professor Bishara said it was relatively easy. Professor Bishara said that the patient has never felt so good, and that he performed 6 months of post-procedural anticoagulation. Well, if we focus on the first part, he said also that it was there were some difficulties along the way. So I wondered, what if it was not Professor Bishara, meaning we are talking about huge experts over here, and if it was difficult for him, what about the rest? So the importance of the learning curve and the definitions of excellent centers, because we know that we get the risk of having patients being over-treated by not expert centers. And this topic of the learning curves, I was checking out a little bit in the literature, was, for example, touched in these interesting papers that dates back to 2002, in which they were trying to see if vascular surgeons could perform angiography, showing how increasing with the number of performances also, of course, the performance was getting better. Up to my knowledge, but maybe I'm wrong, there is not such a detailed investigation in the learning curve we must have before performing properly this procedure. Then Professor Bishara said that the patients said he has never felt better. But what does it really mean in terms of patients' reported outcome? So I think another unmet needs is really the identification of specific patients' reported outcome for these specific scenarios. There were like some examples in the past already reported, as you can see from the literature. We know that we have different tools we can use, but we also know that we have unmet needs over there. For example, in this publication, you see that there are different scores that could be used for evaluating the conditions based on the severity of the eventual post-thrombotic symptom we want to assess. Same thing for this publication, and this very interesting one from the group of Luri that is showing how Villante can actually fail us when we consider chronic venous disease patients, because it's basically detecting the already existing chronic venous disease rather than the one coming after the thrombosis. So we have to be really careful for that, and for this I invite you to read the results of the teamwork we developed with many colleagues involved also here today, following the Winter 2019, in which we were indeed pointing out these topics, so you can dive into this literature aspect. Also because, as you can see, when we look at the results, take for example, the ATTRACT trial, and we are talking about the symptoms, we should really check it out how they are reported in the different publications. And it would be also interesting to understand how much these papers are changing our everyday use. It was very interesting, I think, in the poll to see that there were like quite different reaction in the first answer, as Professor Bishara correctly pointed out. It's true, we had 40% doing something, but 25% in both groups doing something else. And as Professor Bishara answered in the very last question from the audience, he also said that he used 6 months of anticoagulation, but we have paper that indeed are showing us, and this is just the Delphi consensus, so we are not talking about evidence-based data, we're talking about agreement. There is consensus for the use of anticoagulant on 6-12 months, but not that much on the antiplatelet. And this is actually introducing a topic I like to touch later on following Professor Garcia talk on the role of venous inflammation and thrombosis prophylaxis after these procedures. And we conclude with this, the consensus I was mentioning about the use of anticoagulants. It's interesting to notice how the first reason to do something, according to the investigators and the audience, was evidence-based. And on the other side, the smaller numbers were coming from the license for use in venous stenting. So I think we have sometimes a discrepancy between evidence-based data and also the off-label use of something for which we really want to gather together as we were used to do in person, and now virtually, and hopefully soon again in person.
That's
so
quite
much.
excellent and very useful. May I ask Dr. Wasila to start the second case, please?
Yes, now we will fly all the way to Latin America. This is why LAT-AF is here. So this is the Latin American side, and truly honored to introduce a huge figure and a leading icon in Argentina, Dr. Marcelo Dandolo, who will moderate this second session of our night today. Dr. Dandolo, the floor is yours to moderate and of course to introduce the presenter, the speaker of the second challenging case.
Thank you, Dr. Basila. Good morning on this side of the Atlantic. Good morning, good evening. It is an honor to introduce Dr. Oscar Gural Romero. He's a great vascular surgeon in our country. I am lucky to work with him. He is the head of the Service of Phlebology and Lymphology of the University Hospital Favaloro Foundation. So Dr. Romero has the floor to present this challenging case. Thank you.
May I interrupt? Would you like Khaled to put the poll, please? Khaled, put the poll, please.
Thank you for the invitation. I will present the
Just
first
give us
question.
Few seconds for the questions, please.
Before we start. Post-thrombotic syndrome, Villalta greater than 12 with an iliac function of the common femoral. What options do you consider more appropriate? Elastocontration, phlebotonics, angioplasty and stent implant, palma procedure, endophlebectomy, and iliac vein stent.
Khaled, could you
You
show
have the
results,
option
please?
to vote. With 41%, the option endophlebectomy and iliac vein stenting. With this, Oscar, you have the floor to present the case. I will introduce myself. I am Oscar Gural. I work in endovascular interventional service at Favaloro University. I share with Dr. Dandolo, Dr. Ramos, Dr. Di Tomaso. I'm also part of the Ibero-American group of pelvic studies. This is my conflict of interest. a 41-year-old woman with allergy to penicillin and iodine. In 2012, she underwent a surface of the right saphenous vein, has a difficult post-op with pain, edema, interpreted as related to the closed sulfur surgery treated with analgesics and steroids, very unfavorable evolution. Went to the emergency, echo Doppler proved iliac femoral popliteal thrombosis, interpreted as a hit for. She received anticoagulant treatment with acenocumarol for 1.5 years, elastocompression, and phlebotomy drugs. She went for a consultation to our department where she had gluteal edema of the thigh, limping, paresthesia, cramps, change of color in the distal third, collateral circulation, compensating, and epiphyseal varexes, Villalta 12. Echo Doppler showed sequela occlusion of the external iliac vein and the femoral veins. And she had an MRI that showed occlusion in the distal segment of the external iliac and the femoral chamber. We can see collateral circulation and absence of this segment or fibrosis of this segment. We decided to study our protocol, the Ibero-American group. We do an approach with ascending and descending phlebography, where we saw very clearly the occlusion, collaterality of the pudendal and obturator vein to the external iliac vein. We proposed initially angioplasty with hydrophilic wire and stent implantation. We went to hemodynamics, where we spent almost 3 hours trying to go through with different wires and catheters the obstruction, impossibility to go through them. In the 3D reconstruction, we do rotational studies. We found this defect. The catheter with jugular approach went to the external iliac, went to the femoral collateral circulation. The patient progressed, unfortunately, was a failed angioplasty. We could not fix it. We decided to stop the procedure, medical treatment, elastocompression, phlebotomy drugs, and the patient in the successive months after month 4 presented increased symptoms, and the Villalta went from 12 to 14, increased collateral circulation and edema. The ultrasound and CT in our protocol, we do tomography with 3D reconstruction. We can see the increased collaterality and edema. It's possible to have in our team 3D reconstructions that are excellent, very clear, where we can very easily see the collaterality and the defect that we found in radiology, more 3D reconstructions. We proposed, we analyzed the situation, complementary studies, evaluation of allergy. We had to do previous preparation. And I leave Dr. Dandolo to continue. Thank you. I will ask Laura, who is a leader in South Africa. So what do you think about this case? What would be your therapeutic approach?
Could you stop sharing your screen,
Stop
please?
sharing, please, doctor.
And we could have the results of the poll. Sorry, put the fourth question of the poll, Khaled. Fourth question of the poll, please. Khaled, are you with us? Poll, please. Poll question.
In case of endovascular failure, crossing of iliac vein occlusion, what would be your choice? Medical treatment, hybrid procedure, or a venous bypass with or without arteriovenous fistula? Please send your answers.
Can we see the results, Khaled, please?
Uh, so we have 46% selected venous bypass with or without fistula. Now I would like to listen to the president of the Phlebology Association of South Africa, Dr. Laura Redman, for your opinion.
Thank you very much. I would probably go more for the hybrid procedure in terms of stenting higher up to ensure adequate outflow and doing the venous bypass from below to ensure adequate inflow. And I would add a AV fistula to a venous bypass there.
Thank you. Now, I will pass the floor to Dr. Álvaro Sánchez Galán from Spain, a friend. We have shared the Ibero-American group and wonderful discussions in our webinars. Álvaro, you have the floor. Good afternoon. Thank you very much for the invitation. I will talk on behalf of the Ibero-American Pelvic Studies. Dr. Javier Monedero has been one of the first to introduce these procedures. I do believe that the approach of this pathology is divided into before and after venous stents for veins. We used arterial stents for these procedures. We were seeking in May Turner prosthrombotics in the iliac sector with the results we all know. At present, we devote the specific stents results have improved a lot. It's better to have a hybrid correction than do a venoplasty on the proximal fragment of the vein or a short bypass and the rest use the arteriovenous fistula. We have to discuss whether it's final or transient to improve flow in the reconstruction. We cannot permit patients that have an incapacitating quality of life because of severe post-thrombotic syndrome have nothing different than being anticoagulated and using compression stockings. So in this case, hybrid. Thank you, Alvaro. Thank you, Dr. Redman. Dr. Oscar Gural Romero can continue with the resolution of the case. I will share screen.
Stop sharing your screen, Dr. Wasila, please.
We decided to treat the patient. We did ascending and descending phlebography, and yes, we found that obstruction almost that couldn't go through with collateral circulation. We decided to do an incision at the level of the under and above the fold. The junction, we are cardiovascular surgeons. We dissected the iliac femoral and we found the surprise of absence of femoral and external distal iliac vein. It was fibrosis, there was no vein. It was totally destroyed. So we left the catheter in place. We have reached here with the external iliac vein and we needed to complete this segment. We decided to do a prosthesis, PTF, E, 14 millimeters ringed, and do a fistula. The bypass was femoral, external iliac, and arteriovenous fistula with a 5 millimeter prosthesis with rings. In the immediate control post bypass and fistula, we saw collaterality persisted with stenosis and sequela in the external iliac vein. This is the case in the pre-IVUS stage. We are trying to do all procedures with IVUS and streamline and optimize. We decided to place a dedicated vein stent, a 14% 50 at the level, distal level. Collaterality persisted, so we fixed venous dedicated stent, the proximal vein. This is a reconstruction thanks to Dr. Ramos, who belongs to our service, where we can show how the interposition was done, fistula, and then stenting, and the result obtained combining techniques with restitution, and the most important, disappearance of collaterality characteristic of the ad interim restitution at 7 days, first control. With the ultrasound follow-up, we see improvement of collateral circulation and edema. The CT showed 2 months in the protocol, 2-3 months. We do the first CT. We see patency of all segments, and it is likely to achieve with 3D reconstruction the close follow-up of the patient of permeability, patency of the bypass and fistula. The before and after 3 months ultrasound follow-up, you can see also 14 Villalta went to Villalta no higher than 6, 5 to 6, with some collaterality persisting. Post-treatment measures, all patients stayed with clopidogrel 30 days, rivaroxaban 6 months, and follow-up ultrasound and CT follow-up. The question is what to do with arteriovenous fistula. We presented this case because it leads to many questions. First, it is a thrombotic complication immediate to close sulfase, interpreted as a HIT type 4. Should it have been treated immediately with thrombolysis, thromboaspiration, and eventually stenting? How are we managing these chronic thrombotic iliac lesions? Would we propose hybrid resolution in specific situations? What to do with the arteriovenous fistula? Those questions are raised daily. And one of the questions is, how do we fix the poor inflow? What to do when we cannot go through obstruction? Do we use alternative veins or hybrid techniques? The classification presented by Dr. Haley shows that more than 50% of cases are the real problems we see daily. A poor inflow, what does it create? Occlusion of stents. So we cannot fix stents if we have no correct inflow or an outflow. Sometimes what do we do? In the poor inflow, we see the case will be complex. We can optimize, and we see through IVUS doing angioplasty of the femoral vein with balloons. We did very poorly with stents in the femoral vein, most of them occluded. So today we prefer balloons angioplasty, and stenting to the femoral chamber or the profunda femoral. The IVUS permits to see very clearly the restitution of the axis and absence of compression. Other situations in which we see two compression sites with IVUS, where we have an compressive iliac lesion type 1, type 2, described by Rahul. And this situation, how did we fix it? With this defect, we couldn't go through, but we used an alternative vein parallel to the femoral vein, and we converted it into femoral. So this is also an alternative that we have, and the IVUS showed acceptable results. In this situation, it's a more extreme, a patient with a spine surgery, with total obstruction, with pelvic pain, with abundant collateral circulation and palmar. We couldn't go through the obstruction with endovascular approach. We decided to do a mini approach, a primitive iliac, but when we approached, we saw that we should have found the primitive vein was not there. It was totally occluded, and the reconstruction showed that there was no iliac vein. Probably we found filiform fibrosis of all the segments. The only option was to do a femorocavus bypass. At 20 years, we decided to postpone for the time when the patient had more symptoms or higher bilialta. We are very enthusiastic with improving the inflow doing these hybrid techniques. Sometimes we use vein in venous interposition and patch and stenting. It's very important to combine hybrid procedures with venous stenting, achieving the best results. Thank you very much.
This was
Thank you,
quite an
Oscar.
excellent,
Brilliant
quite an excellent
presentation.
presentation.
Brilliant presentation. Thank you. I would like now to give the microphone for further comments.
Thank you very much. I think that was a very interesting case and a very good outcome in the end. I just wanted to ask about the idea of EHIT4 because it was quite extensive to reach up into the iliac. And was the patient investigated for an underlying coagulopathy, or could you possibly have had any pre-existing iliac lesion that resulted in such extensive thrombosis after the radiofrequency ablation?
She was referred to us from another center. In the CTs, there was a May-Turner type 3-4 compression of the iliac artery, internal right iliac artery on the primitive right iliac artery in the Rahu classification. So that was a sign that was not seen in the surgery. So we think that the closure fast catheter was inadequately positioned in the femoral vein, and they did the ablation of the femoral vein and the external iliac. And we've seen this in other previous cases. When we do the procedure, the catheter goes up the femoral vein, and that, if it's not previously controlled, previous to ablation, may cut not the greater saphenous vein, but the femoral vein. I think that this is the physiopathological interpretation of the case. So the big question is, why wasn't it treated immediately? Because she had an alba dolens because of the pain and the claudication, and it was completely overlooked, and it was seen as a complication of closure fast surgery.
For the sake of time, we have to go now to the Q&A. Dr. Wasila, please.
Dr. Lorena, we'd like to select the most liked questions. I think this case, challenging case, it's really very stimulating, and it rise up a lot of questions. And I see also some of the panelists raised up their hands. Lorena, please, go ahead, please.
We always go from little to bigger. So first we start endovascular. We have a repatency rate that exceeds 94, 96%. So most of the times we try to use alternative paths, or sometimes with the cava, lumbar, or we can transform it into an iliac. We are specialized in the transformation. It wasn't a complex case at the beginning. We do a diagnosis phlebography. We have good 3D reconstruction through CT and also ultrasound, but this was a challenging case from then on. Once we started doing the procedure, the only insight was the radiofrequency surgery. In the CT, we saw the type 4 May Turner. So we thought that that might be the origin. We knew we had to do the iliac stenting, but the only way to go through the occlusion, the obstruction, was through an interposition, a venous interposition or a prosthetic interposition, venoplasty, described by Pomerota, was not enough because there was no vein. So we had to really do an interposition there. We choose now the prostheses because it's easier, faster, and many times it's very cumbersome to take out the vein. And it's a much more complex vein, surgery than bypass because of the multi-collaterality. So you have to be very careful. Well, the first parameter, because we are doing a very strict follow-up. If you remember the before and after image at 3 months, we're about 4 months now. At 3 months, we had seen the disappearance of most of the collaterality, claudication, and edema. So the big question mark is, well, I would leave, well, not me, our team has decided to, in our unit with the hematologists, we have several multidisciplines in our team. So we've decided to leave it there for 6 months, the fistula, I mean. If you ask me, I would just leave it there for a year. In my opinion, but and I don't know whether or not I would leave it there forever if it's not generating any sequelae. It is a millimetered fistula. It's not with the vein, and it's easy to resolve endovascularly with local anesthesia in a clinic. I would be able to solve it. It's not a big issue to close it, but the thing is, if I close it, then I think that, I mean, it has a good inflow, but there's a thrombosis, popliteal and femoral thrombosis sequelae. I believe that Dr. Sanchez wants to comment something. No, it's just a very short comment. It's very useful to measure the pressures and the contralateral pressures when you have femoral stenosis. So some say that the time to close a fistula is when you do a pressure measurement and there's no big gradient on both sides. But if there are no symptoms, the fistula helps the patency of the procedure. Thank you.
Thank you, Lorena. Thank you. This was very good. Dr. Marcello, could you please introduce Professor Cees Wittens?
Dr. Marcello. So we will move for the, yes, you are here, Dr. Marcello. Dandolo, Professor.
We will introduce Dr. Wittens. He wants to comment on this.
Yes, well, it's there are a few things that come to my mind related first to the AV fistula. What we did in our, let's say, 15 years experience, we first always made the AV fistula, and after 6 weeks we occluded it with a plug. But we have learned that in fact you can leave the fistula in if there are no complaints. So now we are very, well, let's say, we just wait and see. And if the patient gets complaints of the AV fistula, then we occlude it. So it's not more like a protocol. We just wait and see. I think what's also, we have shown those two cases, and what's very illustrative is that the first case, there was a problem halfway the iliacs where the overlap of the two stents was. And we know with overlap stents, then they got much more rigid and stiff, and they cause kinking. And that's the reason probably why the first one reoccluded, which was luckily good treated with balloon angioplasty. But in fact, if you look at the pathophysiology of the disease in the iliac veins after scarring, then you don't need to cover the complete vein. The only thing why you put in a stent is to keep it open. It's not that you want to cover a diseased wall as in the arteries. It's just, in fact, you dilate the vein, and then you want to support it and prevent it from collapsing. And by preventing it from collapsing, you don't need to support the complete wall. If in fact segmental support would be enough. And we have seen in a huge amount of patients that when you have overlap in stents, then the problem is that you get intima-hyperplasia at that point. It's not real intima-hyperplasia, but it's a thickening of the wall, and that's caused by the compliance differences due to the overlap stent. So in fact, ideally, you would never overlap a stent anywhere. And related to the end of phlebectomy, we've done a lot, and we learned that, of course, there's a big morbidity with it. But ideally, you would like to stent just to the orifice of profunda femoral. And that makes it also difficult because a lot of stents shorten a little bit, and then you don't have the exact precise positioning. And then sometimes they need an extra stent. They put in a new stent 6 centimeters long, again in the femoral vein, to get the positioning exactly where you want it. And that's, again, causing a lot of problems because that's stiff, and that causes the other problem. So ideally, no overlap stents, and going, as already mentioned, completely cover the diseased part, but not cover it completely, but just prevent it from collapsing. And the other thing, what I also saw in the first case was that the pre-dilatation was done at 8 millimeter balloon, and then the stent was put in, and then dilated to 16 millimeters. Well, our cause is always that if you have a trouble doing this, then you might not be able to put your balloon in again after you've put the stent, because the stent cannot, let's say, dilate enough. So we pre-dilate always exactly the same diameter as the stent you're going to use. And there's no worry about causing a bleeding or sharing a scar. That's never happened. So pre-dilate the complete diameter of the stent you're going to use. And that helps you in a much easier deployment with your stent. And of course, well, the last case was really interesting with the completely destroyed femoral vein due to the thermal heat of the catheter used for the venous vena magna. But that was, I would say, we see a lot of those cases when they by people who use drugs, and they inject themselves in the groin, and then the femoral vein is completely gone, and then indeed you need to have a bypass. But crucial is that you have good inflow. If you don't have good inflow, and that's what Human and we made the classification, that if you don't have a good inflow, we don't intervene. We leave it as it is because we only make it worse. But I'm very happy with the outcome you had in those two cases. Looks very promising. Thank you.
Thank you.
Excellent, Professor Witten. It's really down to the point, very useful, and it reflects your very large experience. Thank you indeed. Dr. Wasila, would you please start the
Dr. Rashad, and I would like to congratulate both speakers, yourself and Professor Romero, for such a great work, so challenging cases, and the panelists and the unmet needs by Professor Wittens highlighted so many strong and significant points. Thank you so much. And now we will move to the third section. And this is a quite interesting and very important presentation, which should be presented by our guest today. It's Professor Garcia Marcia, and the moderator for this section will be our compatriot, Dr. Ahmed Gawish. Ahmed Gawish is the Vice President of IVLA, our association, and he's going to moderate the third section. Professor Gawish, please, the floor is yours now.
Thank you, Dr. Wasila. Thank you, Dr. Rashad. It's a really interesting meeting. And for the third part, and last but not least, of course, it's a great pleasure and honor to introduce Dr. Mark Garcia. Of course, Dr. Mark Garcia is a well-known figure in the phlebology field, with great contributions that we all learned from. Actually, he enlightened us with the access PTS, dealing with the very, very difficult cases of chronic deep venous obstruction. And I'm sure that he will also enlighten us with his presentation today about answering the question of does the nature of deep vein thrombosis affect the treatment choice. Please, Dr. Mark, it's a great pleasure to give us your presentation. Dr. Mark, please unmute yourself.
Hello. Hi, thank you. Thank you very much. And it's a pleasure and an honor to be here. I really appreciate the opportunity. So we're going to talk about the nature of DVT and what that how it may affect the treatment choice between acute and chronic DVT. These are my disclosures. So we all know about the clot age definitions of acute, subacute, and chronic, but the truth of the matter is that really doesn't matter. When we get access, we really find out what the age of the clot is. And the time course can give us some information as to how to plan if somebody comes in with, onset of symptoms less than 14 days versus 6 months. But the real answer is the wire test and using tactile sensitivity. Yeah, when we feel the clot, if it's soft, it's an acute clot, and when it's hard, it's chronic. It doesn't matter about when the patient tells you their symptoms started. This determines the next step. So here's the algorithm that I use. When someone presents with DVT, the question is it acute or chronic? When we do the procedure, if it's soft, I'll go to a single session treatment using either suction thrombectomy or angiojet pharmacomechanical thrombectomy, and then adjunctive therapies that are needed. When it's chronic and hard, we want to use standard CTO techniques to cross the occlusion, angioplasty to the expected size of a vein, put the ECOS ultrasound accelerated thrombolysis in, and then adjuvant therapy the next day after a minimum of 12 hours. You can tell by look of venography whether this is something acute or chronic. They look very different. On the left, you can see the acute thrombus inside the vein, which is not collapsed. And on the right, you can see the collaterals and the very diseased and small atretic popliteal going into femoral where there's an occlusion. So when we talk about the acute, the proposed algorithm I suggest is that when we have an acute DVT, particularly when it's less than 14 days, what I do is I send these patients out with a therapeutic anticoagulation, compression, and tell them to increase their activity with walking. We do serial follow-up ultrasounds and physical exams out to 3 weeks. We let them declare themselves, essentially based off the ATTRACT trial, we let them declare themselves as to whether they're developing post-thrombotic syndrome or not. If they are not, we continue to observe. However, if they continue to develop post-thrombotic sequelae with no improvement, we'll treat them before 4 weeks. In 20 years of doing pharmacomechanical thrombectomy, I can tell you that up to 4 weeks, we're about 100% successful in getting out acute clot. It really is not a deterrent to treating them out to 4 weeks. The other thing the ATTRACT trial did show us was that 44% of FEMPOP DVT patients actually went on to develop post-thrombotic syndrome. It is not something we can ignore. We have a tremendous volume of patients who have FEMPOP disease, and popliteal disease is really significant for below knee post-thrombotic sequelae. So the treatment goals are to do single session treatment, eliminate catheter-directed thrombolysis altogether, which eliminates hopefully some bleeding risks and overall costs, and certainly the hospital stay. There are some technical considerations, and this is one that I really harp on in lecturing. Circumferential thrombus removal is the best way to get rid of clot. We want wall-to-wall apposition. It gets us our best outcomes. By doing that, we use what we called rapid lysis technique from back in 1997 when we discovered this technique. And then the other thing is to not under-evaluate the central venous lesions. You need IVUS to look at this. And I think that's why Kevin and Attract were not as successful as they could have been, because they did not treat central lesions. So the treatment options to consider, these really include all of them, but the two that I'll highlight are the rapid lysis, which is pharmacomechanical thrombectomy with a spiraling technique, in addition to the Jedi suction thrombectomy, again, with a spiraling technique. And this is what I'm talking about, wall-to-wall apposition. This is on an angiojet. We use an 8 French hockey stick. We pull back the wire, and it gives us this angle that allows us to spiral through the clot, central to peripheral, and get wall-to-wall apposition with best thrombus removal. When we talk about access site determination, I always want to go below the lowest level of the clot. If by Doppler ultrasound, the popliteal vein is patent, then we'll go popliteal. However, if there's disease in the popliteal vein, you want to go below this to open up that popliteal inflow to the thigh. And so we'll do posterior tibial access. The goal here, again, is to restore direct inline flow all the way from the ankle back to the heart. Some intraprocedural strategies. I start anticoagulation before they ever get on the table using enoxaparin. If we're going to go to lytic therapy, we do a subtherapeutic dose of heparin at 500 units per hour. Again, wall-to-wall apposition. If you're going to do lytic therapy, we use pneumatic compression boots. And at the end, you really need to, again, evaluate the central venous system with IVUS and stent when appropriate. On discharge, I give them my rules of the ABCs of DVT. They are activity, blood thinner, and compression. And I want to make sure that people understand the anti-inflammatory effect, and particularly with COVID, what we've all seen in the last year and a half here is that inflammation absolutely leads to thrombus. Whether it's arterial or venous, it leads to thrombosis. And enoxaparin and heparin are really the best anti-inflammatory anticoagulants out there. So we use enoxaparin that we heard earlier for a month, and then we transition to the oral anticoagulant. And I think that's also a big reason why our outcomes have been so good. So here's a case of a 55-year-old obese female who had a DVT filter, recent TIAs, had an incisional hernia repair, developed a large abdominal wall hematoma, had a surgical evacuation, and overnight developed IVC in bilateral legs, severe swelling, and phlegmasia. And here was her initial venogram. The popliteal vein was occluded. There was a collateral, and you can see everything was occluded centrally through her filter. We took her in. It was a very soft occlusion. I went with the angiojet system, and within 48 hours of total time, we were able to recanalize everything. And she's now 5 years out with no recurrent DVT or post-thrombotic syndrome. This is just an example of the Jedi suction thrombectomy, again, with an 8 French Oscore sheath, giving us that wall-to-wall apposition. We stain the clot, and you can actually see the clot coming in as the suction is going right through the clot here and cleaning it out. And this is 3 minutes of device activation. And in 3 minutes, we had complete removal of the clot. Here's a 42-year-old female who presented to ER with shortness of breath, chest pain, and extensive swelling. She was found to have extensive bilateral PE, but she did not have heart strain, so we were going to anticoagulate and observe. But she did have the extensive occlusive DVT from her iliac down to her ankle, and she was developing phlegmasia. On top of it, she had an enlarged fibroid uterus with heavy menses and would actually have bleeding, breakthrough bleeding outside of her cycle. She was given some anticoagulation to start, and this was her common femoral. You can see the occlusion, and here was her CT showing bilateral PE, but no right heart strain. And this is obviously her very enlarged fibroid uterus compressing her iliac system. And so her initial venogram showed the popliteal to be patent, but it occluded at the adductor canal. It remained with intermittent thrombus all the way through her common femoral, and then you can see her iliac system was severely diseased. This was less Then the total time of this procedure was 30 minutes. This was about 15 to 20 minutes of suction thrombectomy. And you can see the incredible brisk flow through the system. And we did stent her iliac because she was not anywhere in the near future going to be getting a hysterectomy. So just to move on to chronic DVT now, we're talking about people who at least have 3 months, because we like to give them standard of care therapy, make sure that they have had anticoagulation, compression, and so follow-up ultrasound and physical exams. And obviously, if they have little or minimal post-thrombotic sequelae, we continue with standard of care. But if they have significant post-thrombotic syndrome that's affecting quality of life and activity level, we proceed with the protocol that we publish as the Access PTS trial. So I get asked a lot of questions all the time. Can chronic veno-occlusive disease really be recanalized? And I'm going to show you it's absolutely an answer of yes. The oldest clot that we've recanalized is 33-year-old FemPop venous occlusions. So here's a 2-year-old FemPop on a marathon runner who could not stand for long periods of time and certainly could not run at all. And the problem here is not so much the femoral vein. There is some collateralization, but it's this popliteal vein. This is just not allowing flow out from below the knee. Here's an overnight TPA with the ecosystem and balloon angioplasty, and you can now see that there's actually relatively good flow through the femoral popliteal segment. And although it looks irregular and ratty, if you give them an oxyparin for 30 days and continue to follow, and with the ABCs, they will do fine. 2 years out, here's the common femoral and popliteal vein Doppler study showing not only patency, but coaptability. It actually looks normal on venous ultrasound, and she was back running a marathon within 6 months. I put this up just as the protocol so that people can use these slides to follow it. Basically CTO crossing, balloon angioplasty, ecos for at least 12 hours, usually overnight, followed by follow-up ultrasound, or excuse me, venography and adjuvant therapies as needed. The results were published in the Journal of American Heart Association last February 2020. And just a synopsis, the results were statistically significant all around on every metric we measured, whether it was Villalta, VCSS, SF36, or veins quality of life. They all had very huge statistically significant improvement. Our Doppler patency at 365 days, you can see in all these segments, they were more than 90%. So Access PTS was statistically significant on all the metrics that were evaluated. And for patients suffering from chronic veno-occlusive disease with quality of life limitations who have failed standard of care therapy and have no absolute contraindications to lytic therapy, this technique is very safe and effective in improving their quality of life. So in conclusion, if it's soft stuff, it means it's acute. Allow them to declare themselves to develop post-thrombotic syndrome and treat when appropriate. I would say within up to 4 weeks. Single session techniques are what we use with rapid lysis using angiojet or Jedi suction thrombectomy. If it's hard stuff, it's chronic. Treat after failed standard of care therapy, and if it's affecting their activity and quality of life. And this is where we would use the Access PTS protocol. So with that, I want to thank you very much for the opportunity again.
Absolutely outstanding. Thank you very much, Dr. Mark Garcia, for sharing your experience with us. Now, may I ask Dr. Gawish to take over the discussion, please?
Thank you, Dr. Mark. To introduce our first discussant, yeah, here it is. May I introduce Dr. Marcus Foucault. Dr. Marcus is the Chief of Vascular and Thoracic Surgery in Cameroon. Dr. Marcus, are you there? Yeah. Do you have a question for Dr. Mark back here?
Thank you for the questions. To answer your first question, the MRI question, on examine on venous, examine on venous Doppler, if there is no suggesting of a central venous occlusion, the waveforms of the common femoral vein are normal. There are no collaterals around the hip or the lower abdomen. We typically don't get central venous imaging just to try to keep costs down. But if there's any question that there could be a central venous issue, particularly in patients that have ulcers that have been chronic, I have a higher suspicion for central venous lesion at that point. And we'll get MRI or even CT venography to better evaluate so we know what we're dealing with. And your second question again, I'm sorry. Yeah. Yeah, so, sure. So I basically, the slide that I think was most important and the comment was that the goal here is always to get inline flow from the ankle back to the heart, whether that's involving the IVC, the iliacs, or just infrainguinal. In somebody who's very symptomatic, it doesn't matter. So if it goes all the way to the ankle, I'll get ankle access and we'll try to clean out the whole leg. Usually what we'll do is do the leg first, and then the second day when we've cleaned out and have some flow into the popliteal, we'll get popliteal access and clean out all the way the rest through the IVC. But again, a lot depends on if it's acute or chronic, because if it's acute, I try to do everything in single session. And so that may include getting access at the groin or the knee and using the thrombectomy devices to get rid of anything from the IVC down and then the knee to the ankle. But it may take 2 access sites to be able to do that.
Thank you, Dr. Mark, for the answer. Thank you, Dr. Marcus. May I have the pleasure to introduce our next discussant, Dr. Oscar Romero. Dr. Oscar is from Argentina, Buenos Aires, and we are happy to hear your discussion, Dr. Oscar.
Thank you. Thank you very much. Congratulations, Dr. Garcia. We always learn something new from your presentations, Doctor. I agree with you 100%, the difference between acute and chronic, but the pandemic has generated a third option, a very acute event or subacute event or the chronic event. So now we have a third one. The phlegmasia cerula dolens 17 in 6 months, and we had to intervene. We couldn't wait for 1 or 2 days. We had to do interventions in the first 8 to 10 hours because of the systemic involvement related to COVID or because of COVID. So I agree completely with your protocols. We keep on learning from you, doctor, but my question is, what do we do when we don't have any adequate inflow, which is our big problem? So far, we are doing balloons. We improve inflow. We go up to the profunda or deep femoral vein. We are calm, we have it there, and then we go upwards. We improve inflow with balloons only for now. Do you think that there's a research line for the use of a stent in the infrainguinal or below the groin? And another issue is early hyperplasia in vein-dedicated stents. Despite anticoagulation and anti-aggregation, as of the 3rd month, we have seen this, and we have done a follow-up for 5 years, and we see this early hyperplasia. And what's the role, in your experience, the hybrid surgery or hybrid methodologies in very problematic cases where you cannot do it endovascularly? And I have the option to associate this with surgery with or without a fistula.
Thank you very much for the question. For the first question, the inflow, and I agree, there are patients who have serious phlegmasia, ceruleo Dolans, and even Alba. And the Albas are really the critical ones that we need to intervene immediately. And I didn't really talk about that population, but obviously you have to use your clinical judgment and save a limb. So in those settings of the very acute thrombus that needs to be intervened, it really is the same technique. We will get access at the ankle. I'll use a thrombectomy device, usually the 6 French angiojet that goes through and cleans out from the popliteal down. And then we'll get access into the popliteal and use the rapid lysis circumferential thrombus to remove the clot all the way into the iliacs and IVC. And then we'll use IVUS to see if the iliac is indeed diseased, and stent if appropriate. Now, as far as the disease, the early disease that's seen, and to answer your question, I'm not a vascular surgeon, so I don't do fistulas, and we haven't needed fistulas here. The fistulas that I've seen usually come to me after they've failed. They've failed the fistula creation that has increased pressure because of the fistula that from iliac disease, and they were unable to get through the iliac disease and treat. So with those, with that in mind, you know, the problematic area that we see is when stents fail in the iliac system, because they can be worse trying to cross than they are when they don't have a stent at all with the original occlusion. And so what I'll do is a hybrid technique where we use laser atherectomy, actually, just like we would in the arterial system, to spiral and clean as best we can and try to figure out why it failed. Usually, when people fail a good iliac stent procedure, it's because a lesion was missed, they had poor inflow or poor outflow. And so we have to look very hard at figuring out why they did that. The last option is that the patient was non-compliant, and they tell you they took their anticoagulation, but they didn't. So we test to make sure that not only were they therapeutic, but some people also don't respond. You know, they're resistant to some of the new anticoagulants. So we want to test them for anti-10A levels.
Okay. So thank you, Dr.
And the last question for the earlier, remember that I asked?
Oh, I'm sorry, can you repeat that?
Yes, doctor. Regarding the early hyperplasia in vein-dedicated stents.
Yeah, I have not seen that problem yet, so I don't know that I can give you an answer on experience. As I said, we are very, very anal about making sure pre and post stenting that we not only expand the vein as much as possible and clear the clot so that we can get better extension of the stent, but we ensure that with intravascular ultrasound and very dedicated venography to make sure there's brisk flow through the segments back to the IVC. So we really haven't seen much in the way of this early intimal hyperplasia or reaction.
Okay, so we have to move on to our next discussant. For the sake of time, I have the pleasure to introduce Dr. Thiram Narayanan from Singapore. Dr. Syrian, we're glad to have you with us. If you could have your mic unmuted.
Thank you, Mark. Wonderful presentation as usual. It's always a pleasure to hear you speak. My questions regard to this 4-week sort of time frame that you put through with your acute DVT interventions, and I'd just like to understand the rationale behind that. Obviously, from your presentations, especially with the spiral wall-to-wall apposition technique, with suction thrombectomy, your success is extraordinarily good. And I agree with you that technical success, even up to 4 to 6 weeks in removing the clot and a good angiogram, is quite possible. But we do know that the clot is not inert. It's an active inflammatory process. And every week that it's in place, it's creating changes in the vein wall. And we know that there's a rising venous resistance with the scarring, and so that is inversely proportional to the venous return that you can get. The paper has been published on this by us last year of the formula for venous return. So you are risking increasing scarring of the vein wall with every week you wait. What then is the rationale for waiting for 4 weeks, given that PTS can take years to develop and it's you may not get symptoms in 4 weeks? So why not just go at week 1 or week 2 when you see the patient with the success you have and reduce the inflammation altogether?
Hi, good to see you again. And so the answer is simple this. With the outcome of the ATTRACT trial, and we actually instituted this protocol over a decade ago, but with the outcome, it only supported what we did, which is, and I can tell you over and over again, I've seen people that I never thought would recanalize on their own, and they did with anticoagulation. So why put a patient unnecessarily in a procedure if they don't need it? And so that was really the rationale, was initially to make sure that this is not going to resolve on its own. You need to have some time with that. And so we knew that we were very successful in getting the clot out up to 4 weeks at that point in time. And you're right, I think we could say even 6 weeks, but nonetheless, it was really up to 4 weeks. That was kind of our cutoff date to get in and intervene if they had serious problems. Yes, there is a risk of continued inflammation and continued damage, but I will tell you, because we work so hard at getting brisk flow from the ankle back, I am a firm believer that when you reestablish flow and with good anticoagulation compression and increasing the activities, these things will all reverse. And that's why enoxaparin was so important, because I think it really helps with the inflammatory process of what's already there by us being in there and the clot being there, that we've had such good results. And I, even to this date, I wouldn't change it, because I think they've just come so far.
Thank you. Thank you, Mark.
Thank you. Thank you, Dr. Mark. I would now invite Dr. Lorena Grelu to have just one question, the best question she can choose now, and later on we can send the questions. If there are more questions, we can send them by email later on. But for the sake of the session, we will have only one question. Please, Dr. Lorena.
So if you truly don't have IVUS available, I think that's where central imaging that Dr. Wittens talked about earlier is very important before you start. If you don't, you need to know going into the procedure if there is or isn't a lesion there. So I would absolutely do 3D, hopefully reconstructive imaging, at least multiplanar imaging. And then when you do the procedure, the one thing that we see mistaken all the time is that people do things in one view, and that is not adequate. If you don't have IVUS, you should do at least 3 views, AP and bilateral obliques, to really unmask something that may be there. But again, in that scenario, I think it's very important to make sure you have pre-procedure central imaging with either MR or CT venography.
Okay, I'll now give the mic back to Dr. Rashad. Thank you.
Thank you. My pleasure to introduce once again Sergio Genassini, who is going to do the impossible task of giving us take-home message in a couple.
You muted yourself, but I can hear you. So thanks again, and please stop sharing so I can share my last unmet needs. Because indeed it would be impossible to sum up everything in few slides. I think this is a brilliant beginning, of course, of webinars from LAT-AF 2.1. I would like to go back to what Mark said before, and then I was just taking some of his words. So with whatever adjunctive therapy is needed. And I really like to brainstorm on what it means deeply, this sentence, because we still don't understand that much, I think, from the microscopic aspect, what is going on in terms of inflammation and venous thrombosis. We have some hints from the literature. We know, for example, from this publication that drugs that are acting on the venous inflammation could actually act also in the macroscopic aspect of PTS recurrence. This is the Survet trial, for example, that showed a 2 years follow-up what is going on with the use of anti-inflammatory drugs. So I think this is an open point to be discussed. And then I think Mark simply opened a Pandora vase when he started talking indeed about PTS development, starting from the fact that indeed I like to ask all these huge experts how they really define PTS and see if there is an agreement on this definition based also on what is reported in the literature. And then I like to ask all of them if it is really possible to find correlations between all these hemodynamics alterations and anatomic alterations we find, and then the symptoms and signs reported by the patients. This is a very interesting paper from the superficial venous aspects, of course, of the disease, reported by a group of Milan, that was indeed showing the correlations between the visible disease and the, let's say, invisible disease. And this remains, again, in the document we published following the winter meeting, I think, an open question. Particularly if we look at the data we have, I think another unmet needs indeed is the one of randomized comparative trials, because we know from recent literature also that there is, of course, a great value in these technological innovations, of course, in experts' hands. And it has been reported also in this publication. But the authors acknowledge that there is a lack of proper randomized comparative trials. So I think this could be another topic for future discussion. If I should go back to what Professor Gural presented, congratulating him for the amazing job, I would simply quote a paper of psychological aspects of the David-Goliath effect, because I'm not going to go after Professor Chiswittens, who is far more experienced than me on this. So I will simply take the chance to wonder how many centers are really excellence centers around the world of the ones dedicated to these patients' treatment, and on how we can really certify which the proper centers are. I just like to take one last comment on the fact that we were talking about the thrombotic risk after superficial venous procedure. This is in reality quite a big unmet needs that is combining the superficial and deep aspects. We have papers who are showing basically no risk, and we have also a word of cautions back in the years on up to 16% of cases presenting DVT after endovenous thermal ablation. And in reality, it's kind of fake news to consider that foam is giving more thrombosis, because it has also been demonstrated that it is not like that. If you look at this paper in terms of surveys of what we do around the world in terms of thromboprophylaxis after superficial venous procedure, you will see a lot of discrepancy. And you will see that in reality, half of, for example, the Greek colleague are routinely performing a thromboprophylaxis. So there is a discrepancy between groups in the same nations and also in the different nations. This is an equivalent survey from Ireland, showing that 73.3% of colleagues are always prescribing thromboprophylaxis, but just in a single dose in 71.4% of cases. Now, this is pretty interesting. This is the details of the study if you want to dive into it, but I just like to conclude with this slide that is showing in the surgery procedure the thrombotic risk that actually remains high up to 10 times, not the following day or the following week, but up to 6 weeks. So again, phenomena of venous inflammation and thrombosis to be understood a little bit better, for which I will quote also this nice editorial that is indeed calling about the need of proper evaluation of our patients. The final real need, I think, is to go visiting top experts like the one we enjoyed together. This is really something I recommend all of you, visiting Mark and Professor Garcia and Gural, and of course Wittens is the solution to proper excellence in the treatment that indeed giving the take-home messages, I think is the core of today. So just expert hands should touch these patients with the proper tools, validated tools in terms of diagnostics and also therapeutics, so that we can raise significantly awareness on the topic in both health and health professionals, and maybe also in the need of having homogeneous guidelines that, as we know, are not so homogeneous in terms of recommendations. With this, I deeply thank and congratulate LATAM, Africa, so the 2, and then point 1, rotating continent that joined this new initiative. Thank you all.
That's really fantastic. Thank you very much, Sergio. And now it's my great pleasure to introduce my co-chairman, Professor Oscar Bottini, for the closing comments. Professor Bottini, please.
Thank you very much, everyone. There's no need to go any further. We have done everything. I would like to share with you, if I can share the screen, this meeting that we will be holding on June the 5th, continuing with LAT-AF, the one we will have then in 2 weeks' time, same time, and we will have the possibility to speak on clinical cases in superficial venous disease. Remember that we have translation into Spanish, English, and French, and we will have as speakers Dr. Willie Chi and a number of panelists that are chairs of their respective societies and regional leaders. So thank you very much for being here. And Rashad, Basila, and Lorena will close. I only want to remind you that this pathway will go through our next meeting again virtually initially in Buenos Aires, 2021, September, the 3 wonderful days where many more of these clinical cases and papers will be discussed. Thank you.
Thank you, Professor Bottini. This was a great pleasure. Thank you all for attending. We hope to see you with us again in 2 weeks' time in Latin America on the 5th of June to share with you challenging cases of the superficial venous system. And I would like to remind you of the best venous conference of all, the one organized by VWIN in Dubai in February next year, where 189 countries, nearly all the world, are represented. Dubai is a stunning city, charming scenario, perfect for tourism and for networking, and of course, excellent scientific material. Thank you all. Goodbye.